Welcome to all of you and very good morning. Today is the second class of the PG online teaching under the banner of UP-AROI chapter. Dr. Shalin sir, our president, is also here to motivate us. So first of all, we are covering this CNS malignancy, and this is the second class regarding CNS malignancy. And further, four lecture will cover the management of CNS. So anatomy we had already covered, and imaging now we are covering today. For this, Dr. Khushboo is here. And now I am handing over to Dr. Sonia Tiwari. She is a consultant at Kamla Nehru, Allahabad. This session will be moderated by Dr. Sonia. Dr. Sonia, it is on you.
Good evening to everyone, and thank you, Dr. Surbi, for starting all these series for our knowledge, enhancing our knowledge. And so good morning to everyone. Today is the second online class on CNS malignancy, on imaging, on CNS, on radiation perspective, oncologist perspective. So imaging is a very important role in our specialty to identify the target and delineation of the target and delineation of the organ at risk. So that is very important for our specialty, and also to differentiate after treatment for the progression of the disease and the pseudo progression of the disease and necrosis. All these things very important to see and how to manage. So imaging has an important part. So today we have with us Dr. Khushboo Pilania. She is a consultant consultant radiologist in Aizen Imaging and Interventions, Noida. She has a special interest in MR imaging and musculoskeletal radiology. She did her MD from SN Medical College, Jabalpur, and she is a member of Indian Radiological Imaging Association, Musculoskeletal Society of India, and Society of Chest Imaging and Intervention. And she published many papers in national and international journals and book chapters. So, Dr. Khushboo, please welcome in this series to please take over to.
Yeah, hi. Thanks a lot for that kind introduction. It's a great pleasure to be here, and thank you, Dr. Rashi, for making me a part of this. So with the understanding that I had from Dr. Rashi that we'll be talking about the basics of brain tumor to the residents who are here. I think it can be an interactive session. Please feel free to stop me wherever you want me to. And in case you want some more insights or there are questions which are unanswered. I'm not sure how well aligned it will be with respect to the radiation oncologist, though I have tried to make it legible from that point of view. But the issue is that, yes, the gap between us as radiologists and the radiation oncologist, other treating surgeons, physicians, has been there for some time, which we try to bridge by these kind of interactions, wherein we also get a better understanding of what you are expecting from us. And at the same time, you can get an understanding of what we are trying to say from certain things. So with that, let us start with... So what we'll be talking about today is brain tumors and approach to the brain tumors. I will begin with the basics of the brain tumor. The workhorse for imaging the brain tumors is MRI. So gone back are the days when CT scan used to be done. Currently, with the ease and the availability and even the affordability of MRI, MRI has become the primary investigation. MRI, unlike CT scan, is made up of a number of sequences. In CT scan, there is not so much of a burden upon the technologist because it's just a standard set of images, whereas in MR, it is very, very important that a protocol is in place because a number of sequences are there. So even as a radiation oncologist, as a treating physician, we need to know that the importance of getting a particular set of sequences for our patients, because very often these patients are uncooperative, in which case if we just go in and sit into the MR machine with multiple sequences, it will not be possible. So the basic sequences and how to read them and what is important with respect to each of these sequences is important. The 5 basic sequences in brain MRI are what I'm showing in front: the flare, the T2 weighted, T1 weighted, diffusion, GRE. These are the basic images which are a mandate for every patient who's being scanned for a brain tumor. So let's see how these sequences look like and how we can differentiate one from the another. The centermost image is a T2 weighted image. The most important thing we need to remember with respect to identifying the T2 weighted images, that the CSF is white. So whenever you have a white CSF, it is a T2 weighted image. Then we have a flare image, which is just a T2 weighted image, but in which the fluid has been suppressed. So the fluid becomes black, rest all remains like a T2 weighted image. So in this case, we can see that the fluid is black and it is again a T2 weighted image. T1 weighted image, the fluid is also black. And in this case, we can see that the white matter is white. So this is the white matter. Peripherally, we have the gray matter. Whenever the white is white, it is a T1 weighted image. So these 3 are the basic images which you should always be able to identify one from another. You might face a difficulty beginning on, but every time as a resident, if you try to look at the images again and again and ask yourself, it's not so difficult to differentiate at least these 3 subset of images. And always on every MR film or whatever you're seeing, they are always mentioned also. So that will help you. Then we have the diffusion weighted images. Diffusion weighted image should always be read alongside an ADC map. So very often the ADC maps are not provided when you're getting the scan done at some tertiary center. Sometimes they will not provide because ADC maps are calculated from the diffusion weighted images. Always look for it. This is the set, this is the diffusion, and this is the ADC maps. You might find a difficulty early on again in differentiating these subset of images, but they are mentioned on the film. And when you look at them again and again and again, you will realize the differences because the diffusion weighted images mimics a flare image, but the sharpness and the resolution is much less. And the ADC map is just a kind of inversion of a diffusion weighted, where whatever is black becomes white. So the CSF starts appearing white. But these 2 images always and always have to be seen together to understand how we are characterizing a particular lesion on diffusion. In fact, for that matter, only looking at an ADC map makes more sense rather than only looking at a diffusion weighted image. This is a GRE sequence. Again, you can just see the marking on the film and understand this is a GRE. The importance of this image is that this is to look for hemorrhages. Hemorrhages are often not picked up, hemorrhages, calcification on the standard images. And always look at the GRE images, which will help you differentiate these. So apart from the basics of the brain MRI, which included the T2 weighted, flare, T1 and diffusion and the GRE, when we are talking about brain tumors in particular, we need to have a few higher or advanced set of images alongside, which includes a post-contrast T1 weighted images, which should be mandatory done at least for the first time when a patient is being imaged for a brain tumor, and even going ahead depending upon the time interval at which we are following it up. The perfusion sequences and the MRS, which is the MR spectroscopy. So how do I approach a brain MRI? Once I have got all my set of images together, so it is also very important. Another thing which is important is because as a radiation oncologist, when you will be referring patients for a brain MRI, it is good to give them a protocol, because at a lot of places, the way I'm seeing nowadays, the scans are not being monitored. In case they aren't being monitored, and if it has not been conveyed very thoroughly that you are trying to image a patient for a brain tumor, characterization or post-operative assessment of tumor response, it will not be taken care of in the manner it should be, because as I said, MRI is made up of a huge number of sequences, and if the correct sequences have not been done adequately, the entire purpose is defeated. So having said that, now I will talk about, once these images have been acquired, which image do I look at in what sequence, so that I can derive the best from it. Because if you have so much of information in front of you, if you do not go one by one and in a step-by-step approach, most of the times it becomes a jumble. So the first thing that I look for is the flare image. You look at your flare image, look at the symmetry, and if you see anything bright, keep it in your mind. That is something which will be alarming. So flare image is the most important for detection of the presence of a lesion, and at the same time, what kind of an edema is there surrounding a lesion. Once you've seen a lesion on the flare image, then you look at the same site on the T2 and the T1 weighted image, which helps you characterize the lesion. If you are actually looking at the size of the lesion itself, T2 weighted image is the best, because it gives you the margin of the lesion much better than the flare, because in cases of flare, the surrounding edema is also there, and it is difficult to differentiate the primary lesion from the surrounding edema. The T1 and the GRE sequences are again helpful in further characterizing. They help us in telling whether or not there is hemorrhage within the lesion. Then the diffusion weighted image, which helps us in, again, understanding the character of the lesion. So whether there is restricted diffusion. Restricted diffusion means that something which is bright on the diffusion weighted images and dark on the ADC maps. Again, my stress is that just do not look at your diffusion weighted image and make a conclusion. If you see something which is bright on the diffusion weighted image, always go back and look at the same lesion on the ADC map. If you see it becoming dark, that means, yes, this is a restricted diffusion, and which usually signifies either an infarction, or if it is within an obvious mass, it signifies the higher cellularity of the mass or the more aggressive nature of a mass. So, now that we have done this and we've understood the basic of a brain MRI, that how we need to look at the brain MRI, which are the various sequences that we are, considering, which sequence should we look to answer a particular question. So for example, the question that is asked to me is whether there is a lesion on this MRI or not. Which sequence will I be looking at first? I will be looking at my flare sequence. If you ask me, what is the size of the lesion? Then I'll be looking at the T2 weighted images. If you ask me, what is the character? Is the lesion aggressive? I will be looking predominantly at the post-contrast images and at the diffusion weighted images. So we need to get an overview of this. Now that we have an overview, whenever we are dealing with brain tumors, I think these are the primary questions that you will ask to me as a radiologist, or you will ask to yourself when you are treating a patient. So definitely the first question is that when you see a lesion on the MRI, you've picked up a lesion. Your question will be whether I'm dealing with a tumor or not. The next question, if you say that, yes, I'm dealing with a tumor, is it benign or malignant? Is it a primary or a secondary tumor? Is it intraaxial or an extraaxial tumor? Can this be resected? Are the various vital structures involved? So these are the subset of questions that you are looking at an answer to. And let's see what best an MRI can do. So when we are talking about whether or not it is a tumor, the other common differentials that we have in our mind is that in case it's not a tumor, it could be an infection. Could it be a stroke, a hemorrhage or something? A thorough knowledge of the presentation of the patient, the history of the patient helps us solve this a large number of times. There are times when the dilemma persists, but for those, there are certain features which will help us, differentiate one over the other. But always we need to remember that one modality, radiology by itself, is not complete. Neither is clinical examination by itself complete. So when we work together, then it's easier to come to a conclusion. Then we ask ourselves that is it benign or malignant? Certain alarming signs that you should be looking at on the brain MRI, which will tell you that you're dealing with an alarming lesion, are the presence of enhancement. Whether there's a restricted diffusion. By restricted diffusion, I will again stress that I mean something which is dark on the ADC maps and bright on the diffusion weighted images. Whether there is significant hemorrhage within the lesion. Is the lesion intra versus extraaxial? Extraaxial lesions are less often malignant, except in cases of disseminated metastatic disease, than the intraaxial lesion, whether the lesion is single or multiple. So these are few things which help us understand how alarmed we should be when we look at a lesion. Then to differentiate primary versus secondary, of course, it's single versus multiple, intra versus extraaxial. Imaging wise, how do we differentiate an intra from an extraaxial tumor? As I said, the importance to differentiate is number one, because the extraaxial tumors, primary extraaxial malignant tumors are less likely. Yes, if it's an extraaxial tumor, it can be metastasis. The other thing is the treatment approach changes from an intra to an extraaxial tumor, the resectability approach changes, and at the same time, the prognosis changes. So it is very, very important to be able to differentiate whether what we are dealing with is an intra or an extraaxial tumor. A very simple, the first way to approach it is look at the overlying bone. In case the overlying bone appears involved, it is more likely to be an extraaxial lesion. So for example, in this case, you see the entire osseous cortex. The cortex is thinned here. The entire black structure is the calvarial cortex. It is thinned here. Look at this case where the cortex appears of a similar thickness all through. So whenever the cortex is involved, we know we are dealing with an extraaxial lesion. Then when we look at a lesion and we see this kind of buckling, so you see the gray matter has buckled together, the white matter has been chinked in between. Such a kind of an appearance should, make you think that what you're dealing with is an extraaxial tumor. So extraaxial tumors are something which push the brain parenchyma inside rather than infiltrating them directly. However, in this case, we can see that the lesion is well within the parenchyma. There is significant surrounding edema. So when we see these kind of features, these are the features which will help us differentiate an intra from an extraaxial lesion. So now that we've discussed our issues, how we will try and address them better, again, a stress is on the fact that a comprehensive tumor protocol should be in place for us to be able to answer these questions. This will include the routine sequences, which will be T1, T2 flare, diffusion, GRE, followed by a perfusion contrast study, spectroscopy, and DTI and fMRI, depending upon the setting where you are, if it is available, if it will, if you're planning to resect a tumor, in which case this becomes really important. So rest all sequences are not so much of a rocket science, because anywhere where you're getting the scan done, T1, T2 flare, diffusion, GRE are almost always a part of a normal brain MR protocol, may it be a tumor protocol or not. Contrast is always given in case asked for, but not everyone does a perfusion scan. So this is something which you can stress on. For perfusion, it's not mandate that you need to have certain softwares in the machinery. Yes, to get the colored images that we get, that software is important. But even if the acquisition has been done in a perfusion mode, and you speak to your radiologist or the technologist and get the acquisition done in the perfusion mode, it helps us answering a lot of questions. So perfusion is, I'll just come to it also. And apart from it, to understand the diffusion weighted images. So what is the role of the diffusion weighted image? The way I said earlier, it helps us in understanding the grading, the aggressiveness of the tumor, the cellularity, how cellular the tumor is. Often it helps us in differentiating post-operative injuries. So in case during surgery, if some kind of an infarction or stroke has happened, the extent of the peritumoral edema and also the diffusion weighted image is, extrapolated to diffusion tensor imaging, which helps us in integrity of the tract. So this is an example where we see how the diffusion weighted images helps us in differentiating the glioma grade. The last column is all of the diffusion weighted images, the ADC maps of the diffusion weighted image. As I stressed earlier also, maybe at times, even if you're not looking at the main diffusion weighted image, looking at the ADC map is of utmost importance, and you should always stress wherever you are getting these scans done that the ADC map should be provided. Anything which looks dark on the ADC map, so you look at this, and in this case, this is much less dark. So whenever something is dark on the ADC map, it means that there is restricted diffusion. Dark on ADC maps means low ADC values, means higher cellularity and more aggressiveness of a tumor. So it is what we are dealing with is a glioma in A, B, C, all three images. These are the post-contrast T1 weighted images. These are the FLAIR image. So as I said earlier, that FLAIR is one of the best for detection of the tumor. So we can see the tumor well in all these three cases. On the T1 post-contrast, we see that this lesion shows much less enhancement, and at the same time on the ADC maps, it is much less dark or much less hypo-intense, the way we use on in radiology. A tumor which enhances less, is less dark on the ADC maps, is of a lower grade. As we go down, we see this tumor which again enhances less but more than the first case, and at the same time, but there is significant amount of low signal on the ADC map. So this is of a higher grade than the above tumor. The third lesion, when we look at it, it shows much more intense enhancement and it is much more darker. So these ADC maps and enhancement characteristics help us in deciding the grade of the glioma. This is again a case wherein we can the ADC maps can also help us in differentiating whether or not there is a post-operative injuries, and so in this case we have the diffusion weighted image. This is the diffusion, not the ADC map, but we see this bright lesion. This was the tumor. The patient was operated for the tumor. At the same site, we did not see any enhancement post-operative. Some enhancement was seen after some time in the same location, but at the same area, we were seeing a large area of restricted diffusion. That means it was a case where there has been a post-operative injury, post-operative infarction in the same location. And over time, it resolved with gliosis and ex vacuo dilation. So this is where when these the routine, the T1, T2 do not show a change and we are suspecting some kind of event that has happened during surgery, look at the diffusion weighted images. Sometimes post-op infarctions and all might have happened and which can be picked up well. Now coming to the MR perfusion. So as I said, no dedicated, sometimes we definitely have these dedicated softwares for MR perfusion, which are, more helpful in giving us beautiful colored images. If the machine does not even have the software, the acquisition can be done and a reasonable amount of information can still be gathered without any additional cost on the patient, and it hardly takes another 2 to 3 minutes extra time in the machinery. So the idea behind a perfusion sequence is that we try to assess the brain tumor while the contrast is going into the brain tumor, as against the routine post-contrast images where we see the brain tumor only when the entire contrast has gone into the brain tumor. Because you also understand that every infection will enhance like a tumor as well. So when both of these lesions enhance, giving contrast into the brain does not really suffice a purpose unless we understand the pattern of enhancement. In cases of brain tumors, the enhancement is due to neoangiogenesis. There are new vessels which are formed within the brain tumor which cause enhancement of the lesion. Whereas in infection, in cases of infection, there is not so much of neoangiogenesis. There is more of an inflammatory response, which is called the blood vessels to dilate, a lot of inflammatory reaction pooling in all around the lesion. And that has caused the kind of enhancement. By doing perfusion images, we help to understand that whether the enhancement pattern is just due to pooling in of contrast or is it due to a neoangiogenesis, in which case there are new blood vessels which take up the contrast and they show a particular pattern of enhancement which is different from that which is due to a simple inflammatory response. So let's look at these perfusion MR and see how it is making the difference. This is a T1 weighted images. You see that the fluid is black. So it's a T1 weighted image. This is a T2 weighted image. We see the lesion very well. This was not seen so well on the T1. This is a post-contrast T1 weighted image. I do not see any significant enhancement. The perfusion weighted color maps, of course, we do not see any significant perfusion in this region as well. So we know that what we are dealing with is not as aggressive. Again, when we look at this next set of image, we see the lesion. It shows good enhancement, good irregular peripheral enhancement. The perfusion sequences also show good color uptake in this region. So as I'm telling again, these colored images may not be available in all machineries unless they have the software, but the assessment of the enhancement can be seen with the help of your technologist or the radiologist. So this was the perfusion. Apart from perfusion, the another very important tool when we are looking for brain tumors is the MRS. MRS is the MR spectroscopy. Without the MR spectroscopy, it is very, very difficult to characterize a brain tumor, at least in the first instance. When you're getting a brain tumor imaged, please insist on an MR spectroscopy. Another important thing which you should insist at your end is that when MR spectroscopy is being done, the spectroscopy should be done on the tumor, and you should also get values from the normal brain parenchyma. The spectroscopy can be a single voxel, multi-voxel. It can be at different TE or TS. In such cases, if it is not possible for you to get into the technical details, it's important to keep your radiologist in loop and just tell them what your concern is. And that you should also just convey this to them also, that you also want a spectroscopy in normal brain parenchyma. This I am insisting because not everyone does it. And it's a very simple concept that whenever we are trying to interpret something, we should always have a baseline. And over time, we've realized that the baseline between human to human changes. So you should have a normal baseline value of the metabolites of your patient in his or her normal brain. And then you should analyze that baseline value of the metabolite with the changes that are happening within the lesion of concern. So the bottom line is, get an MR spectroscopy done in the normal brain as well as within the lesion. Take your radiologist in loop when you are trying to interpret this. Just a simple overview of what we mean by MR spectroscopy. There are three important metabolites. So with MR spectroscopy, apart from seeing how the lesion is, we try to see what are the various metabolites within the lesion. There are certain metabolites which are markers of aggressiveness of a tumor. There are certain metabolites which are markers of the fact that the tumors are of a particular nature over the other things. The three most important things that you should be conversed with is choline, creatinine, and NAA. So this is how an MR spectroscopy graph looks like. This is how it looks like in a normal brain. This is the choline peak. That is the amount of choline within the brain at that place, amount of creatinine within the brain at that place, and amount of NAA within the brain at that place. It should always follow such a slope. So in a normal brain, choline will be least, then creatinine, then NAA. Whenever this slope changes, we are dealing with a lesion. So whenever we are dealing with any lesion and the slope changes significantly, that means we are dealing with a lesion which is altering the metabolites within the brain parenchyma. So it is an extrinsic lesion. It is a lesion which has come from outside. If it is something within the brain, there will be a dip in all the metabolites in a proportionate manner. So I think somebody wants to ask me something.
No, Dr. Khushboo, kindly keep it up.
All right, okay. So this is what we call the Hunter's angle. And when we move from choline to creat to NAA, when we see such a slope, we know we are not dealing with something aggressive and we are, a bit settled. Now, when we look at tumor, this is how a tumor generally shows. We usually see a tall choline peak. So the choline which was here, which was the smallest, it becomes the tallest. And then the NAA drops down. So the angle is reversed whenever we are dealing with tumor. Whenever you see such a reversal in angle, we need to be alarmed. But at this point, a simple tip that I will always I always think at this graph always also be given. So this 150, 200, 250, these are an idea of the absolute values. You should look at these absolute values and compare with the absolute values in the normal brain. So for example, this is my graph for the brain within the brain tumor or within the brain lesion, and the choline value is say somewhere around 220. If I see the choline integral value within the normal brain, so if this is the integral value of the choline in the normal brain, and suppose this was also around 220, then even though the fact that there has been a change in the pattern of the metabolite levels, it is not so much alarming. I hope I'm getting that clear, that we need to also see the values in the normal. We need to see what is the baseline value of that patient. If the baseline choline is also 220 and the integral value of choline in the lesion is also 220, then even though we have a reversed angle, what we are dealing with is not so aggressive. So because MR spectroscopy, though it has been stressed a lot, it is not so helpful in differentiating a brain tumor from infections like tuberculosis, and often sometimes from metastasis, for the same reason that we always keep on looking only at these graphs and we do not go back and look at the integral values, because the graph will be the same for tuberculosis also and for a glioma also. Then for us, the dilemma remains there, that whether we are dealing with is a tuberculoma or a glioma. So in these cases, try to look at the integral values, for which you will have to insist wherever you are getting your scans done that a voxel needs to be given in the normal brain parenchyma as well. Okay, so these were the entire basics of interpreting a brain MR. Now I will just go ahead and show a few examples of how one tumor looks from the other. What are the alarming signs that we see? So when we are looking at low-grade gliomas, as I said, something which is low-grade does not show as much enhancement, does not show as much restriction on diffusion-weighted images. These are the two important things that we look at. So this is a very characteristic example of a dysembrioblastic neuroepithelial tumor. We see a lesion in the temporal lobe, these tiny cystic areas, the bubbly appearance. It is like a book picture. So if you look at such a lesion, you don't need any histopath diagnosis. You know you're dealing with a DNET. It does not enhance. Anything which is not enhancing is not so aggressive. Though, of course, the astrocytomas also do not enhance, but the ones which are not enhancing are the low-grade astrocytomas. So I'm not saying that brain tumors always enhance. All I'm saying is that a brain tumor which does not enhance is not as aggressive as the other tumors which enhance. So DNET, as I said, it's a benign lesion. It has a bubbly appearance. Temporal lobe is the most common site. Gangliogliomas, these often show enhancement. These are more well-defined, but they do not show so much of surrounding edema. They do not show restriction on diffusion-weighted images. These are few very typical book pictures. So if you see such tumors, you should keep your index of suspicion very high. If you see such a tumor, such a lobulated enhancing tumor, you are dealing with a ganglioglioma. Pilocytic astrocytomas. Pilocytic astrocytomas occur in childhood. They are infratentorial tumors. They show these, mural nodule kind of enhancement within the lesion. And again, this is a rather low-grade astrocytoma. So an example where I can show you how these MRS and perfusion help. So this is the MRS of the same patient. The choline NAA ratio, when we look at the choline NAA ratio, there is a reversal of the Hunter's angle. This is CREAT2. Please make a note that there are two creatinine metabolites on the MRS. One is the CR2, which is not the one which we talk about so much. We talk about the CR1, which lies after the choline. Whenever choline is high, NAA is low, we know we are dealing with a brain lesion. Again, what I would insist is that look at the integral value of the choline. If it is higher than that in the normal brain parenchyma, that means it's definitely a more aggressive lesion. If it is lower than the normal brain parenchyma, then in cases where this angle is also reversed, we should be thinking of other less aggressive lesions like tuberculoma. The perfusion beautifully shows that though the tumor showed significant enhancement, we can see significant enhancement within the lesion on the post-contrast images, but on the perfusion, you do not see so much of brightness. So that is what I was stressing, that in cases there is not so much of neoangiogenesis within the tumor, the perfusion sequences do not show that kind of an uptake, which helps us differentiate that whether the enhancement is just an inflammatory response or it is due to the neoangiogenesis, and how much is the extent of neoangiogenesis, which helps us differentiate the aggressiveness of the tumor. So though the tumor enhanced, which raised an alarm that it could be an aggressive tumor, but on perfusion, there was very low perfusion, which tells us that yes, the lesion is not so aggressive. The other, another primary brain lesion that we come across very often is the oligodendroglioma. Oligodendrogliomas are more of a peripheral based lesion. See, there are features which differentiate it from the routine gliomas, like these brain cortical thickening involvement, more cortical based lesions. So you would see the brain parenchymal cortex thickened, but very often it is not so easy to differentiate oligodendrogliomas from the other astrocytomas on routine imaging. And, maybe a histopath or other advanced imagings are always needed. Nevertheless, it's good that we know certain signs which point towards a particular lesion more than the other. So for example, presence of calcification is more towards an oligodendroglioma. You see the typical peripheral cortical based enhancement again more often with an oligodendroglioma. Again, we have varieties like anaplastic or oligodendrogliomas, which becomes a higher grade tumors in which again the tumor infiltrates more towards the cortex. But then, there are no real definitive ways on imaging where I can differentiate maybe a high-grade glioma from an anaplastic oligodendroglioma with high grade of confidence. And again, we have a diffuse astrocytoma. So you see a large lesion, did not enhance much. But the way the infiltration and aggressiveness was, you can see the mass effect on the pons. It is being shifted to the opposite side. So this is a diffuse astrocytoma. The diffuse fibrillary variety of astrocytoma, which also does not show as much enhancement. And at the same time, the important thing which we need to understand is that we are seeing the diffusion weighted images. The lesion is dark. It is bright on the ADC map, which means that it is not so much cellular. The aggressiveness is less. Yes, it is an astrocytoma, but it's a lower grade, not so much of a high grade astrocytoma. So again, the same lesion, the fibrillary astrocytoma, which does not show as much enhancement, but yes, there is aggressiveness in the sense that it is infiltrating the adjacent brain parenchyma. The anaplastic astrocytomas, again, we see an aggressive appearing lesion on the FLAIR image. This does not show as much enhancement, though we are seeing some meningeal enhancement, but not so much of an enhancement. The glioblastoma multiformes, on the other hand, do show more enhancement. So we see this enhancement. Enhancement is often, often misleads us because sometimes even the higher grade tumors do not show enhancement. So also look at the diffusion weighted images. If you see such restriction on diffusion weighted image, it is more often a higher grade tumor, because an important characteristic is that lower grade tumors do not show restriction on diffusion weighted images. Lower grade tumors do not show enhancement, but even the higher grade tumors may not show enhancement. So that is something you should keep in your mind. Again, when we come to interpreting the MRS, we see a tall choline peak and a short NAA. The angle is reversed. Remember to look at the integral values. This is the integral value. See this value in comparison to the normal brain always. If this value is less than the normal brain, think twice before labeling the lesion as an aggressive tumor. Then we can have multicentric GBM. The most often dilemma in such cases is whether we are dealing with a multicentric GBM or it is a disseminated intracranial metastasis. So there is no other way apart from histopathology to be able to say that with absolute certainty, or, after we have ruled out the presence of disease elsewhere in the body by doing a PET scan or by doing other tests on the patient. Sometimes, yes, MR spectroscopy helps because, as I stressed, in cases of MR spectroscopy within metastatic disease, the choline values will not be as high. So that is sometimes of a help, but not always. MRI is also of great help in, follow-up of the glioblastomas. So when a patient is treated by surgery or radiation, the tumoral bed starts showing changes. Now, these changes on a CT scan can no way be differentiated from residual lesion to post-treatment changes. MRI is the only way where we can try and make some difference. And that too, a standard MRI may not be able to help us much. So we need a proper post-contrast perfusion and spectroscopy to be able to help us. So when we look at this lesion in a post-treated case, it is difficult for me to say whether these are post-treatment changes, whether these are radiation-related changes, whether this is a residual tumor, whether this is a recurrent tumor. So when we do contrast, we see enhancement, and we are tempted to say that this is a residual disease or a recurrent disease, but we should always remember that in post-treatment patients, up to a particular time, that is up to sometimes over an year, enhancement in the tumoral bed persists. It can also be more than what was seen pre-operatively. Why? Because we've gone into the brain parenchyma, done some kind of injury to the native brain parenchyma as well. We have generated some kind of an inflammatory response. Now, for us to differentiate whether the enhancement is due to that inflammation incited by the surgery or by the radiation versus a residual or a recurrent disease is important. Perfusion often helps because, again, when you look at these perfusive enhancement, which means that the enhancement is not due to neoangiogenesis, it is most likely an inflammatory response, or the enhancement due to fibrotic changes which have happened into the brain parenchyma. So this increases our index of confidence to say that what we are dealing with is radiation necrosis, and let's just follow it up and maybe it will resolve. A proper timing protocol will be that within first 24 to 48 hours, we should do a plane and contrast study. After 6 weeks, again, a plane and contrast with MRS and perfusion-weighted perfusion sequences. Compare it with the previous scan, understand the way perfusion has changed, understand the way spectroscopy has changed, and then at a later date, depending upon what kind of a primary tumor we were dealing with, we can do a screening of the spine as well. So these were about the more important tumors in the brain. A few other not so less commonly seen tumors in the brain that will be, I'll just put some images across. So this is a primary CNS lymphoma. Whenever we see a tumor with a periventricular distribution showing good enhancement, showing good restriction on diffusion weighted image, CNS lymphoma should be considered. So again, we see a typical periventricular lesion showing good restriction. So this is a diffusion weighted images. The lesion is white on diffusion. I would stress that do not interpret with only this single image. Look at your EDC maps. If these white areas turn black, only then is it restriction on diffusion weighted images. If these white areas do not turn black, that means it is not restricted diffusion. So if you have a periventricular lesion with restricted diffusion, please think of CNS lymphoma. So metastasis, as I said earlier, that these can be both parenchymal or extraaxial, but if you have multiple extraaxial lesions which are looking aggressive, think of metastasis. Primary aggressive extraaxial brain tumors are very less likely. So that ways. This is just a case of leptomeningeal enhancement where you see extensive nodular meningeal enhancement. Such a pattern of enhancement, especially in a known malignancy, will be a metastatic disease. One of the commonest, the commonest brain tumors, which I have not mentioned as yet, is the meningioma. It is a benign brain tumor. It is an extraaxial tumor. So when you have as I said, that when you have an extraaxial aggressive lesion, it is less likely to be a primary brain tumor. But if you have an extraaxial benign appearing lesion, think of meningioma. Meningioma has a very typical appearance. This is a case of an aggressive meningioma. So meningiomas can convert into more aggressive lesions, anaplastic meningiomas, in which case they need to be operated upon. Quite often, they are very benign appearing extraaxial lesions causing pressure effect on the brain parenchyma and not so much infiltration of them. So this is what I have. If there are any questions, I'll be happy to take.
Thank you so much, Dr. Khushboo,
Thanks.
for this wonderful lecture on MRI and enhancing our knowledge on this thing, because that MRI we see in day-to-day practice and dealing with these brain tumors and all. I think there is not much questions. One question is lymphoma lesion on MRI that you already discussed. What anything else if you want to say about what are the characteristic of lymphoma lesion on MRI? You can.
So the first thing which we need to understand is that whether we are dealing with a primary CNS lymphoma or a secondary lymphoma. In a secondary lymphoma,
Yes.
we will know that the patient is a known case of lymphoma, in which case life becomes easier for us. The dilemma occurs when we are dealing with a primary CNS lymphoma, which are rather rare. But if we have that typical history, the patient is compromised. And in such patients, when we see a periventricular disease, we should always ask ourselves that why are we not missing on a periventricular lymphoma? Because often
sometimes the difficulty is to see whether it is a primary brain tumor or lymphoma or the secondary. This is the confusion if there is a single lesion in the brain.
Yeah.
Yes.
Totally agrees. So, but the
And another yes.
Go ahead. Yeah.
Another thing I think I want to ask what there is a difficulty after treatment of the brain tumors, especially astrocytomas and other. So when there is a residual disease or there is a pseudo progression or necrosis, this is difficult to recognize. So if you want to say something, how to?
So in these cases, these are often as much difficult for us, but the important ways where we and how we can make a difference is, number one, to have all these series of images with us. If we just shoot one set of image which is done at one point of time and try to answer these questions, it is difficult. We should have pre-op image, immediate post-op image, and the current image all together, analyzed together. The images should have been acquired with a proper protocol, which will include diffusion weighted sequences, GRE sequences, ideally a perfusion and spectroscopy. When everything has been done together, it becomes much more easier, and we can quite confidently differentiate that what we are dealing currently is a residual disease versus a tumor radiation induced necrosis, or we are dealing with, if we are dealing at an even later stage, are we dealing with a recurrent disease. So getting the series of images together will help us bring that answer.
I think this is the same question asking what is the post-operative patient for adjuvant radiation, delineating the residual disease and edema is challenging. How to differentiate between vasogenic and disease-associated edema? So,
see, even the disease-associated edema is mostly a vasogenic edema. If what we are talking about is the infiltration, the disease infiltration, to differentiate the disease infiltration versus the edema, as I stressed, we should be looking at the series of images, and the current image should be acquired with a proper protocol, which will include a proper contrast enhanced perfusion image and a spectroscopy. So when we put all of these together, if a lesion does not show a good perfusion, it can show enhancement, but the perfusion will not be as much. It means that we are less likely dealing with a disease recurrence or a residual disease, especially when the same lesion had shown a good perfusion on the pre-op images. So those kind of comparisons become very important.
Another question is could you please explain the concept of GRE and diffusion imaging?
See, the concept of these, the entire concept of MRI is a bit tough. It's about the way the various protons in the brain react to the various changes in the magnetic fields, and on the basis of them we generate various images. In in a very broadly described term, what we can say is that diffusion weighted images help us understand the cellularity of a tumor. So how many lesions are closely packed, how many cells are closely packed with one another is something which the diffusion tells us. So if something is highly cellular, that means it will show restriction on diffusion weighted images because they're all clumped together and they are not moving. If something is not moving, it becomes bright on the diffusion weighted images. So a simple example is that infarction. So that is a dead tissue which does not move in the acute phase. So it is bright. Similarly, highly cellular, highly packed tumors, they will not move so much and it will show restriction on diffusion weighted images. GRE has a concept wherein things, there are certain, elements which show extensive reaction to the changes in the magnetic field, and they start appearing black and they bloom out. So hemorrhage and metal products, they show that kind of a blooming effect. So when you see something black on a GRE sequence, you're dealing with a hemorrhage or some metal or calcium within the lesion.
There is one more question. Meningeal carcinomatosis feature.
So I showed one of the images of leptomeningeal carcinomatosis. It is a disease where you see diffuse enhancement along the sulci and the gyri of the brain. The enhancement is not very smooth like a line. You see nodular enhancement. So that is when you are dealing with a diffuse meningeal carcinomatosis or a leptomeningeal dissemination.
Dr. Khushboo, one question from my side. How to differentiate between the vascular metastatic tumor with infarct, as in case of the RCC, because most of the brain secondaries are the vascular type lesions. So how to differentiate between them?
Okay, so I was expecting a tough question from you. Yes, that is definitely a tough call. But what happens is that when we look at the GRE sequences, these highly vascular tumors will also show the vessels within. And here there is a very important role of the perfusion sequences. These highly vascular tumors are at the same time due to neoangiogenesis, as we've been stressing. So when you do these perfusion images, you see intense enhancement and you see intense blood pickup. Whereas in cases of hemorrhages, there will be no enhancement as such. There can be some reperfusion enhancement, which is very different from the way we see with these vascular tumors.
Okay.
Look at the GRE sequences. Look at the GRE, the post-contrast perfusion. We will be able to differentiate.
Thank you so much. I think there is no more question in the chat box. And so thank you so much, Dr. Khushboo, for this lecture on the imaging. Very wonderful lecture.
Dr. Khushboo, first of all, thank you very much. Very well articulated and obviously a very tough call. You were not given a brief, and I think you were not given much of a brief other than to say, just introduce the topic to a bunch of radiation guys, and you've done a fantastic job with that. But I can see where the questions are coming from, and when people are asking questions, what exactly is happening about diffusion imaging, perfusion imaging, and spectro and all the rest of it. So yes, they are interested in understanding the technology, and so that they can make some sense of it. Now, obviously, in 1 hour, this is not possible. I accept completely. There were some important things that I think need to go in. Conventionally, from the radiologist, from the radiation oncologist point of view, and this is really directed to colleagues and everybody else who's listening here in radiation oncology, that what we call edema in radiology is actually tumor. When you look at a a histo-radiological set of analysis. So, for instance, if you have a tumor, you have a low-grade or a high-grade glioma, you'll have an enhancing portion, and then surrounding that, on the T2 or the T2 flare or the flare, you have what we call an edema. We treat both the enhancing part as well as the flare portion, knowing fully well that there is tumor there. That's an important difference. So we therefore definitely, from the radiation oncologist point of view, we must cover the edema is not classically edema as we understand, as we would as doctors understand it, but it actually is tumor infiltration. And as you know, the tumor goes along the white matter tracks, the association fibers, the longitudinal, the horizontal, and transverse, and so on and so forth. So this is a concept that must be explained, must be understood by the radiation oncologists. The second thing is that a very valid question they were asking about diffusion and perfusion imaging, and of course you've tried to explain it, but in such a short time. Fundamentally, if you have cellularity, there is restriction of water diffusion, and to see a treatment effect, the tumor cells would undergo apoptosis, and therefore the diffusion would be more free. So a tumor response is seen by a change in diffusion indices. You can see enhancement both in necrosis as well as in a recurrent tumor. The difference is that in a necrotic area, your perfusion parameters would be lower, but in a tumor, there will be much more perfusion. This is it. So this is a sort of thing, I think, what I would request is that we'll ask you to come in again, and we'll give you a set of a brief about what are the precise questions that we have from the point of view of mechanistically explaining MRI to radiation oncologists, because these are the questions that people typically ask. Where is tumor? Where is no tumor? Is there a response? Is there a progression? Is this post-treatment enhancement? Is this pseudo-progression? Is this pseudo-response? These are the kinds of challenges that come across to us, and we will put these questions again before you, and we're not going to leave you, because I think you're fantastic. And it's just that a very clear mandate and brief with precise questions are given. And thank you so very much for taking on an absolutely impossible task of, condensing the story in 50 minutes. Thank you. And wonderful choice, Dr. Surabhi. I can see you are able to pick on and zero in on phenomenally good talent. Thank you so very much for taking all the efforts.
Thank you, sir. Thank you, Dr. Khushboo. Thank you, Dr. Sonia. And thank you all the participants. There are many queries regarding the video upload. Yes, very soon we will upload the lecture video also, and we'll let you know soon through mail ID. It was fantastic lecture, Dr. Khushboo. Thank you so much.
Thank you for those kind words. Thanks a lot.
Thank you so much. Thank you.
Thank you. Thanks a lot.